It's really interesting, isn't it? Because there's no question that in the 80s and 90s, rectal cancer surgery and outcomes improved. And everybody forgot about colon cancer for a long time. They thought, well, actually, if colon cancer was fine, there was nothing much to it, and you could take it out whatever way you wanted to. But of course, the principles of doing the surgery properly are really important for any cancer, whether it's colon, rectal, or anything else. I'd like to tell us a little bit, Phil, about colon cancer story.
So it did seem bizarre that we were spending all this time looking at the minutiae of little nicks in the rectum, and yet we were seeing, some colonic surgery come out, which was full of gashes and slices and perforations. So I think there's a pelican philosophy, which is all about what's the anatomy like, what's the best way.
Holy plane.
The holy plane, and what the how should we approach the removal of this anatomical area, and that you head down the holy plane, and you must find it, but yet we had never applied that to colon, and so we were seeing such wide differences in appearance with these specimens that we thought we'd take some photographs, because it must make a difference. If it makes a difference in rectal cancer and low rectal cancer, it must make a difference in colonic cancer. So we took some pictures. Nick West looked at them all, graded them in the same three grades that we had in rectal cancer, except changing the rectal for colic. And we could see when we did a study with 399 cases that actually it made sort of about a 20% difference in outcome. Now, what chemotherapies make a 20% difference in outcome? I couldn't think of any, especially at that time. So we thought the surgery must be important. And as it happens, because of the Stockholm experience and the intercommunication between surgeons, Torbjörn Holm met Werner Hohenberger, Pelican met Werner Hohenberger, and we got to look at his specimens. And again, it was a sort of Norwegian moment. It was chalk and cheese. These specimens are just so totally different to what I was used to seeing. We were seeing high ties, we were seeing the windows in the peritoneum, and we were seeing the transverse colons, which of course don't have a great outcome, coming out in a completely different fashion. And Werner's survivals were excellent. They were higher than anybody else was reporting. And then, again, through the pelican ties, we get to see the handiwork of the Japanese. And this is from the Tokyo surgeons, so Professor Sugihara, Professor Koibashi. And basically, you can see that we've got the high ties there, and the anatomy is perfectly intact, so it's been beautifully removed, but they're shorter specimens. So here we have some anatomically not very well removed specimens, some very extensive anatomically removed specimens, and some less extensive but also anatomically removed specimens. So we have three different ways of approaching this, and clearly there should only be one way of approaching this, which is the way that gives us the best survival. Now, people adopted this, so the early adopters in Bergen thought they reproduced the improvement by using complete mesocolic excision, and in Hillerød in Denmark they also did a study where they adopted complete mesocolic excision, and they again showed improvements, and in Stockholm Torbjörn Holm ended up proving the improvements. Now, what we're really missing is a huge, massive study. Some of the studies that were done in the later stages of TME in order to really prove the importance of this, because there's still a lot of debate. Is it about the anatomy? And I don't think anybody can argue really about the fact that good anatomical removal of whatever you remove is fundamental. But there's a lot of debate about D2, D3, and we still haven't defined the absolute value of that. But I believe personally it's It's got to be a good anatomical resection. You shouldn't be cutting into that mesocolon where the lymph nodes are. You need to be handling those specimens very sensitively, and you should get better outcomes. So I think there's still work to be done in colon, and of course it's 60% of all of the specimens and all of the patients, so it's really important that work is done in that area.
But the big aspect of what's called CME, complete mesocolic excision, there are two really big things. One is the complete mesocolic, the other is the high ligation of the artery right up high, which is something Bill taught me when I was a trainee. And the problem with that is that the colon has got sort of quite a complex blood supply, quite complex arterial blood supply.
And venous particularly.
And I think, especially with minimal invasive or minimal access, what we should call it, with laparoscopic and robotic, it's difficult and can be a bit dangerous, which is why you're right, Phil, there's no question it's very good anatomical surgery, and if you practice this you get better outcomes. And actually one of the interesting little papers I wrote a few years ago, editorial, was the H factor in surgery, because if you think about it, it was Bill Heald, Torbjörn Holm, Werner Honenberger, and then Angelita Habragama. So because we had the X factor, so the H factor in colon and rectal cancer surgery. I got an editorial on that.
What a pity I'm not called her.
Yeah, exactly.
Didn't you have an ancient Greek too, Herodotus or something?
No. But there's no question. Basically the paper that the editorial said it's the quality of the surgery aiming to do better, or in Angelita's case, the quality of leaving a rectum alone, which has had a complete response, the thought process behind that. But the quality of the surgery is for anterior resection, for abdominal perineal, and for colon cancer.
The question back to the surgeons are, if this is really important, shouldn't the surgeons be really expert at it? And how many colorectal resections do you need to do to be as expert as you should be in order to get the best results here?
I think it's interesting because this is complete mesocolic excision is talked about, and it's been practiced a lot. And for instance, if you look at people who do laparoscopic colon surgery and now robotic colon surgery, they're trying really hard to do complete mesocolic excision approach. So I think everybody who operates on colon and rectal cancer tries to follow the principles of TME, the principles of low rectal abdominal perineal excision and complete mesocolic. So it's getting there, but it is, you're right. I don't know the answer to the question, how many do you need to do before you really put it?
Throughout the years that this was going on, the surgeons were specializing progressively in a different way in different countries. So, in Germany you have visceral cancer surgeons, who the same person doing a pancreas as a rectum. In America and the UK we have I've seen in America as a visitor, I can remember when there was proctology. They were the sort of operated about as far as their finger reached, but the general surgeons did all the colons and the rectums, and they've gradually got their own society. Now the big association, the American Society of Colon and Rectal Surgeons, and likewise in the UK we have our own association, and we've started, the general surgeons hung on to the colons for years, and now I don't think anybody other than they still do.
Well, because of emergency surgery.
Well, emergencies, yes.
So that is an issue.
It's better to keep them overnight and give them to a colorectal surgeon, I would suggest.
But I think we should move on, because this takes us really into multidisciplinary teams, doesn't it, Phil?
Yep.
The whole aspect of combining, as you said, Bill, combining the people who, some people might do all the rectal cancer like you in Basingstoke, some might do colon cancer. And the big challenge at the moment for all of us is do you categorize yourself by the tools you use, whether you use your hands in open surgery, whether you use a laparoscope, whether you use a robot. And this is becoming almost the current right now. What people are focusing on rectal cancer is, are you using a robot, a laparoscope, or your hands?
I mean, I think it's a complete fallacy, because all the trials show that there's no difference between open, keyhole and robotic in terms of your long-term outcomes. And if you're, the key thing is to concentrate on being a great surgeon. And I don't mind how you take it out, as long as you're a great surgeon with that tool. And okay, you can argue that there are a few lesser complications ultimately with keyhole, and there may be a few lesser with the very expensive robots. But at the end of the day, you want to end up with a patient who's alive, who survives and doesn't get a recurrence. And you know, that's not about the technique, that's about the skill of the person doing it, the skill of the radiologist in predicting whether you can get it out, whether it needs preoperative therapy, which is the skill of the clinical oncologist or the medical oncologist increasingly. And ultimately, you have to have a great surgeon who's been trained by great anatomists, and the anatomists are incredibly important. So it's about the skills of the entire team. The skills of the surgeon are fundamental in this game, and we should be trying to be better surgeons and better pathologists and better radiologists.
You better explain to people who was on this slide, Bill.
Before he does that, can I just make the point before we finish that discussion? I vote definitely for the specialization should be in the anatomy of the area being operated upon. So that I think a rectal, you need a person to do the rectum who really understands the detailed anatomy of the pelvis, because to be perfectly honest, we are still learning it, the detail, the layers, deep down. And the one thing about the robot is you do get magnified views, and you do get the ability in specialist hands to demonstrate that anatomy and operate on it in a very, very precise way. Yeah. But I think the idea that that we went through a terrible period when the laparoscopic surgeons would feel they could do anything, even areas where they had no special organ understanding or anatomy understanding, but because they could work that instrument, they went to do it. I think in your area, if you want to be laparoscopic or robotic, fine, but stick to your area.
And also that's where the quality control comes in. It doesn't really matter what you use, Phil, does it, if you get a good specimen. But take us through the people on this.
So on the left-hand side, as we look at it, we have Werner Hohenberger, the doyen of colonic surgery, and below him is Torben Holm, who was our doyen of the low rectal cancers and subsequently also complete mesocolic excisions. Then there's a character with a red tie, which is a younger me. And then the character next door to me is, of course, yourself, Brendan, which I think most people will recognise. A younger Brendan. And then there's the quizzical Soren Lauerberg, who is the inquisitor, excellent surgeon who has done so much to improve outcomes or transform outcomes in Denmark. And then you have Thilo Wiedel with the glasses to the left of Bill in his glory. Thilo is a fantastic anatomist from Kiel who has taught us a lot. Then you have the maestro himself with his Petrovsky gown awarded in Russia. That was one of the most pleasurable days of my life, watching Bill being dressed in public by these three young ladies, and beautiful, beautiful gown. Then we have the red scarf is our clinical oncology colleague, Rob Glyn Jones, and then Chummy, who is Now you'll have to say Chummy's surname.
Sinetamby.
Sinetamby. Chummy was the Royal College of Surgeons Professor of Anatomy and went on many of our escapades around the world teaching the anatomy to surgeons, which was fantastic. And then the doyen of radiology sitting down at the bottom enjoying her screens is of course Gina.
And I mean, I think it's really important, the anatomist, Thilo Wiedel and Chummy Sinetamby. Chummy was a surgeon and then went into anatomy, became professor of surgery in the Royal College of Surgeons, and Bill and I had a wonderful relationship with Chummy.
We've left off so many people, of course, you can't get them all, but Ayhan Kuzu, for instance, from Turkey, has somehow mastered particularly beautiful cadaver dissections. I think he has a secret method of preparing cadavers which somehow preserves the planes, and I think some of his work is fundamental.
So let's move on to the multidisciplinary team approach.
So this is our multidisciplinary team, growing by the year really. So we have the key relationships between the radiologist with the surgeon pathologist, and all of us with the oncologist. Increasingly gastroenterologists are important because we're seeing cancers earlier, and colorectal nurse specialists are incredibly important because they do a lot of the translation to the patients and telling the MDT about the patient situation, which is terribly important. And a lot of this surgery is about images, so the MRI images are before and after chemoradiotherapy, the quality of the specimen. The cross-sections give you the areas where you might be concerned about whether it's metastatic spread or direct spread, and we can look at that in greater detail with whole slides. But most importantly, we all need to keep good records, because unless we can record what we do, we then can't tie it into the outcomes, and you won't know if the radiologist is any good. Because unless you do the correlation between the radiology form, the pathology form, and ultimately the outcomes and local recurrence patterns, then that's the only way which will grow as a team, will grow more information and will then determine how we manage these patients more effectively. So the MDT, terribly important. At the centre is the surgeon, but the radiologists, the pathologists, the oncologists and other people play major roles to help us improve outcomes.
And of course, Phil, you were very much one of the leaders of our TME MDT project, which we ran to try and bring across that whole relationship between the surgeon, the radiologist, pathologist, the radiation oncologist, and our specialist. And I think that's really fundamental. And I think Pelican was a great achievement that we actually put this course together, and Bill and I operated and tried to produce specimens which you gave us good marks mostly, and sometimes bad marks.
Usually great marks, but you actually brought the MDT into the mainstream, and everybody followed, and it was tremendous, and that was appreciated by Sir Mike Richards when he gave you the National TME programme, and subsequently Darzi gave you the low rectal cancer programme. Because you talked the talk and you could do the job, and it wasn't academic. At the end of the day, you produced the beautiful specimens, we had the great radiology, we had some good pathology, and we basically were able to say, when you have everybody doing a good job, you get a so much better outcome.
But I think part of the success of the programme, which is that we brought people together in Basingstoke and subsequently in Leeds. We had our MDT and then our low-rec programs, which is quite difficult now in the current climate to bring MDTs together. And I
don't think it would ever have worked virtually, do you?
No, it would never have worked virtually. You have to meet people.
We've got to get back to people meeting in the evenings and talking to each other in a real way, just as we three are together.
And you brought everybody to Basingstoke, which for most people would be the place they'd never go to.
Yes, exactly.
But we did go to Leeds.
We did go to Leeds. Well, it's not much better, really. We weren't taken to some nice little beach somewhere, but there we go. So out of that, we produced the Mercury studies, which are still fundamentally important. And that's the first Mercury team there. And you can see many of the people are still around. And we must pay tribute to those people that put such a huge effort into those early studies. And the early studies proved the impact of the radiology. So Gina did an amazingly good job, correlated it with the pathology, and ultimately correlated it with the outcome, that the MRI could predict outcomes for local recurrence. Not quite as well as pathology, I would say to Gina, but very well and beforehand, so you could actually manage those patients and give preoperative treatment to those patients who needed it, which reduced the local recurrence rates. And then the low rectal cancer study, Mercury 2, coming along behind, which again was fundamental in this whole multidisciplinary team message. And then also the MRI for tumour regression grading. These were all done as great scientific studies which gave clear results and published in great journals and had worldwide impact. And they were all funded by Pelican, and people put a lot of hard work into them, and they were coming from this little place in Basingstoke.
I think the Mercury study still stands out, and I think it was the correlation of the radiology with pathology, wasn't it, Phil? Because, radiology was shadows really, and then pathology was but actually we could correlate, and that was where I think the key was to be able to, and what Gina and Phil, you both worked together very much to correlate the actual pictures with the pathology.
It really did start the realization that we've got to try and work out as much as we can about the cancer before we operate on it. To fail to prepare is to prepare to fail. And what Gina and this study did, and all of us did really, but was, I think, start something which is still far from complete, because I still travel around the world plenty, and I did until the COVID, still going a bit. But essentially, the quality of the images people see, I would say still in most places, is not anywhere near as good as the best imaging. So Gina started defining T2 weighted imaging and the necessity of small fields and correct angles and so on. Very, very important, and still not complete, still not finished. Well, none of these things are finished. But
if you look at the tumour regression, because we're now in an era where we have probably 10 to 20% of people who have chemotherapy have a complete clinical, radiological, and pathological. So what we try to do nowadays is not to take the rectum, which has been cured of its cancer, if we can at all avoid it. So, and that's where the radiology is really helpful, isn't it, Phil? But we had to define the abnormal and then to move towards normal and what is fibrosis and response, which of course has been the whole journey of Pelican and of Mercury, hasn't it?
These sorts of studies are the sorts of studies you need for radiomics. So you need the pathology and the radiology together, so you can annotate where the cancer is on the pathology. That can then be translated into where the cancer was on the MRI, and then you can put the beauty of radiomics into it. So these sorts of studies are the studies that need to be repeated in high resolution.
Okay, so I think that's really very helpful. The way we came together as surgeons, radiologists, pathologists, nurse specialists, radiation oncologists, and oncologists. It's a really important part of our lifetime.
And we've had a lot of fun.
We've had a lot of fun.
Thanks to you guys and Pelican and everybody's efforts. And of course, the people who most benefited, ultimately the patients, which is fantastic.
Find a whole series of videos and links to our series of discussions around rectal cancer at this address. And if you have any suggestions what we might cover, please let us know. Thank you very much for joining us.